Can anyone guess? Rash with morning.
Systemic sclerosis.
No, rash. Rash at the extensor areas.
Oh, psoriatic arthritis.
Yes, psoriatic arthritis. I personally faced this case. That is psoriatic arthritis. And in case of psoriatic arthritis, you have to look each and every corner of the patient's skin, looking for the rash. So you have to know what are the important areas looking for the psoriatic rash. First, you have to look at the nail. Then you have to look at the extensor surfaces of the, then you have to look at the knuckle. Then you have to look at the extensor surfaces of the elbow. You have to look behind the ear. Then you have to look, you have to tell the patient that, examiner that, I want to examine the private parts, including the around the nipple, below the breast, in the axilla, in the groin, around the navel, and also at the gluteal cleft. You have to specifically tell the examiner that this area I want to look for if there is any rash there. And also check the bilateral knee, whether there is any rash there. A real-time case happened in the Delhi center that the patient had rash over both his knees, but that rash was covered with the gown, and the examiner did not check for the rash over the both knee joint. That was a case of psoriatic arthritis, and he was not given the mark in the physical examination section in the identifying physical sign because he missed the rash over both knee joint. So you have to look underneath you have to raise the gown to look at both elbow. But to look for the private part, you have to take permission from the examiner. Remember that. You have to know all the possible areas where you can get the psoriatic rash. This is very much important. Okay, let me tell you another case. These are real exam cases. These are not my synthesized cases. A 35-year-old male has come with hand pain. After entering the station, you are seeing that he is a patient of acromegaly. You all know how you all will be able to recognize the acromegaly patient. That is protruded jaw, prominent supraorbital ridge. So what do you think? What is the case? What is the cause of hand pain in this patient?
Carpal tunnel syndrome.
Wonderful. Carpal tunnel syndrome. So what important differential diagnosis you have to exclude in this patient for bilateral carpal tunnel syndrome? Can anyone tell me? I have already discussed.
So cervical myelopathy.
How to exclude this?
By chasing Hoffman.
Wonderful.
Both
yes. By examining the jerk of both hands. By checking the Hoffman or at least supinator jerk. And only for not checking this thing, the candidate in the Dhaka Center lost his mark. The British examiner did not give him any mark because he told me that he told that he did not check for the jerk. I have seen the feedback. So the important differential diagnosis of bilateral carpal tunnel syndrome is cervical myelopathy. There is also another differential diagnosis, that is peripheral neuropathy. You have to do the examination for that. But at least don't forget to check for the jerk. Then come to the next case. A 32-year-old female with hand pain. After entering the station, you are seeing that she has some puckering of mouth. So what can be the cause of hand pain in this patient?
Systemic sclerosis.
Yes, but what is the cause of hand pain? I am not.
Raynaud's phenomenon.
Yes, Raynaud's phenomenon. And she's taking atenolol. She is taking atenolol for her blood pressure as a blood pressure medication, and she's also taking OCP. So what safety netting you are going to tell her? Can anyone reply?
It should be substituted to another medication.
Yeah, tell me in your own way how to make the safety netting. She takes beta blocker and she takes OCP. So can please one volunteer tell me what specific safety netting you have to tell to this patient. Dr. Mahfouz, you can tell.
Use gloves, avoid cold water.
Wonderful.
Cold
Use
exposure.
gloves. Wonderful, wonderful, wonderful. Use gloves, avoid cold water. Then?
About cold environment.
What about
Vibrating
medication?
words.
Wonderful. Then, what about the medication?
Medication should be, I change the beta blocker with ACE inhibitor. Beta
No,
blocker
you
should
can
stop.
You just have to tell that stop the medication, and I will talk to the consultant to replace this medication with some safer one.
Safer one, okay.
You don't have the right to change the medication. Your role is as a register there. You are a coordinator, remember. Then what about the OCP?
I will talk to the women doctor. He will give you an alternative method of contraception.
Yes, wonderful. Very good, Dr. Mahfouz. Then let me discuss another case scenario. This is actually Delhi case. 40-year-old male with hand pain. After entering the station, whenever you ask what do you mean by hand pain exactly, he gave the 3 examples, he denied. Whenever you asked him, can you please show me the site of the pain? He is showing you that he is having some AV fistula cannula. So what is the cause of hand pain in this patient?
Block AV fistula.
I will expect answer from another candidate, Dr. Mahfouz. You have already given answers of so many questions. Can anyone else answer this question? I have already discussed.
Infected or blocked AV fistula.
Yes, then?
Cellulitis of the surrounding
tissue. Wonderful. Yes, this is actually paid case of the Exam Center. So then another case, 60-year-old female with joint pain, with hand pain. After entering the station, after asking the patient that what do you mean by hand pain exactly, is it joint pain or color change or tingling numbness, she's telling that I'm having joint pain. And he was seeing some Haberdan's note and Butcher's note. So what is the diagnosis in this case?
Osteoarthritis.
Yes, osteoarthritis. These are real exam cases that came in the basis exam. I have collected it over 3 years. So another case is a 32-year-old female with hand pain. So after entering the session, she is telling that my hand pain is due to joint pain and I have morning stiffness. And the joint pain is bilateral symmetrical in both wrist joint and both knee joint. So what is the diagnosis here? Yes, someone is already answering. Yes, rheumatoid arthritis. So these are real exam cases. What I will do, I have prepared the detailed elaboration of each cases, and I will make group between the active participants, and I will provide the cases to each of you to make practice between yourself. And in the second class, after discussing the prompts of the gastroenterology system, I will assess the homework. I will practice with each candidate separately how you have gone through the cases, how well you have prepared. From the musculoskeletal system, I have collected about 29 cases. And with the detailed elaboration, also with the what to do for the physical examination, what to tell for the investigation, and what to tell for the management, I will provide to each one candidate. Your homework will be to get prepared of the musculoskeletal system before the next class, and come with the preparation or the homework in the next class. And you have to keep your, I will assess you how well you have gone through the homework. In this way, after discussing each system, I will provide the cases, and in the next class, I will assess how have you practiced and how have you taken the preparation. But remember, to pass the PACES exam, partnership is very much important. You have to make partner between yourself, because you can practice with me at least 1 or 2 cases. But if you make partnership between yourself, you can practice anytime. That's why I want to build partnership between yourself. I will give case to everyone, but not the same case for each 2-1. I will give separate cases. But during the next class, I will provide all the cases to individual one, the PDF of all the cases, so that after the completion of the course, you can take preparation of your own. But before, you have to practice. You have to assess each one using the mark sheet. Using this mark sheet, you have to assess each one. You have to practice it. You have to practice it like a mentor. Like whenever you are practicing with some other candidate, you have to assess how can you assess him or her regarding the physical examination, regarding the physical sign, communication, differential diagnosis. If you are able to do this way, I can guarantee you will be passed. And I will suggest you to rate your confidence before starting the course from 0 to 1, like 0 being the lowest and 10 being the highest. And I can just make a guarantee that after completing the course, how confident you feel. This is for my personal assessment, that just make yourself that how confident are you right now, and how confident are you about the approach to the LCC after ending of the course. Just compare the assessment. So is the hand pain clear to everyone? If it is clear, then I can approach to the next case, that is low back pain. Do anyone have any kind of question regarding approach to the hand pain? If it is clear, please give me a thumbs up so that I can proceed for the next case. Okay. So the next important case is low back pain. Low back pain is another very much important case for PACES exam. It frequently comes in the PACES exam. So how to approach the low back pain? Remember, for any type of pain, try to look at the site, because it is from my real experience, from the real exam cases. One time at the Pondicherry, a case came with low back pain. So many candidates thought that it is something like the musculoskeletal pain. But whenever anyone asked, can you please show me the site? She was pointing at her lumbar region, at her right flank. And that was a case of pyelonephritis. It was not due to any musculoskeletal cause. That's why I have put this thing here. Always try to pinpoint the site of the pain. Then come to the approach to the low back pain. First, approaching to the low back pain, first you have to ask, is there any morning stiffness or not? And if there is morning stiffness, whether it is more than 30 minutes or less than 30 minutes. If the morning stiffness is more than 30 minutes, then the differential diagnosis is seronegative spondyloarthritis. There are 4 seronegative spondyloarthritis. There are ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and enteropathic arthritis. I will tell how to screen for each differential diagnosis. Then if there is no morning stiffness, or if the morning stiffness is less than 30 minutes, remember, there can be morning stiffness, but the morning stiffness is less than 30 minutes, then the cause is most likely mechanical. So for the PACES exam, the important differential diagnosis of mechanical low back pain is trauma, septic arthritis, osteoporosis, osteoarthritis, metastasis, multiple myeloma, PLID, and psoas hematoma. I will discuss one by one how to exclude each one. So for ankylosing spondylitis, first discuss about the inflammatory low back pain. For ankylosing spondylitis, actually there is no screening question. For psoriatic arthritis, you have to ask, is there any skin rash? For reactive arthritis, you have to ask, is there any pain where urination? And you have to take history, whether there is any history of casual sexual contact. And for the enteropathic arthritis, you have to ask about the bowel habit. Any loose motion, any blood in the motion. You have to ask separately. That will make an impression to the examiner that you are excluding Crohn's disease and ulcerative colitis. So any loose motion or any blood in the motion. Then for mechanical low back pain, the cause is trauma. Any case of pain, you have to exclude whether there is any trauma. Then the septic arthritis. The septic arthritis are the important septic arthritis are discitis, TB, and brucellosis. So I will discuss how the case comes. For brucellosis, it actually comes in the Middle East. It usually does not come in the India and Bangladesh. It is actually a common case in the Middle East. There is a history of drinking camel milk and low back pain. Then osteoporosis. Osteoporosis especially comes against the background of either Cushing disease or celiac disease or due to postmenopause. So in the history, you will get certain clue of either Cushing disease or celiac disease or postmenopausal women. Then automatically the differential diagnosis of osteoporosis will be osteoarthritis. Then metastasis. In the metastasis, you will directly get a clue from the past medical history. So the patient tell you that in the past medical history, if the patient has past medical history of breast cancer, then this can be due to recurrence of the metastasis. In the past medical history, the patient can tell you that he had a history of resected prostate cancer. This can be a case of metastasis. So in this way, the metastasis case comes. Then come the multiple myeloma. It is actually less important. Then PLID. You have to exclude the PLID by asking the question that does the pain goes anywhere, like the lower limb. Then the psoas hematoma. Psoas hematoma actually comes on the background of valve replacement.
What
in the
is
past,
PLID?
Sorry?
So what is PLID?
Prolapse of lumbar intervertebral disc. Whenever asking the negative symptoms, I will discuss what are the red flag signs. Whenever asking the red flag signs, like does the pain goes anywhere, like the lower limb, that is signs of radiculopathy. That indicates PLID. Actually, direct PLID case does not come, but it will come as a differential diagnosis. Are you getting my point, Dr. Neha?
Yes, sir.
Okay. Then comes the psoas hematoma. Actually, psoas hematoma comes on the background of valve replacement. So in the past medical history, the patient will tell you that I have history of mitral valve replacement. And now I am having valve low back pain. Probably there will be some evidence of warfarin injection. And you have to find out why this warfarin effect is increased. Probably in most of the cases, there will be a history of taking antibiotic like the azithromycin. These are the real exam cases. So I'll give you some cases. I will see who can answer the questions. But before that, I want to tell something else. That is, after asking for the morning stiffness, you have to ask the Otipara, then liquor, then you have to ask the red flag signs. So what are the red flag signs of the low back pain? The red flag signs is any loss of sensation around your private part. Does the pain radiate elsewhere? Any change in sensation in your lower limb? And does the pain wake you up from the bed in the night? These are the red flag questions. I am repeating once again. Any changing sensation around your private part, that is perianal anesthesia. Any loss of sensation in your lower limb, that is anesthesia to the lower limb. Then nighttime pain, do you think that the pain is severe enough that wake you up from the bed? It indicates mostly metastatic pain, sometimes inflammatory back pain. When the pain is so severe that he has to get up at the night, that is a red flag sign. So for any low back pain, you have to ask first the morning stiffness there or not. Then you have to analyze the low back pain using the Odipara, then liquor, then you have to ask the red flag signs. Is this clear? Then you have to examine the gait for each patient, because by examining the gait, you are excluding the complication by the physical examination. For every low back pain, you have to examine the gait. For hand pain, you have to examine the functional capacity of hand. And in case of low back pain, you have to examine the gait. Sorry. So this is the way the low back pain comes. If it is clear, then I'm going to discuss some real basis exam cases. If it is clear, just give me a indication that you are clear. No question is there. Okay, let me discuss some real exam cases. Let me see who can answer the questions. A 65-year-old man with low back pain. Regarding past medical history, he is telling that he is taking treatment for prostate cancer. He is on ongoing treatment. And regarding the drug history, he is taking some medication called flutamide. So what is the cause of low back pain in this patient? Can anyone answer?
Metastasis.
Think once again. It's a tricky question.
Osteoporosis.
Due to? Yes, osteoporosis. Due to what? One has answered, Dr. Siddharth had answered. Osteoporosis due to flutamide. Yes. This is not due to metastasis. Remember, he is already getting treatment. He is on treatment. And he is getting flutamide. That is anti-androgen. This is a tricky question. I was just checking who can answer this question. This is due to osteoporosis due to anti-androgen. That is flutamide. This is a real exam cases. This has come in the basis exam. Is this clear? 10. Another, this is 60-year-old female with low back pain. This pain is for the past 2 days. And regarding the past medical history, she has diabetes and she has got a skin scratch while doing gardening 4 days back. So what can be the cause of low back pain in a patient with diabetic and history of skin scratch? That is skin injury.
Discitis.
Wonderful, yes, discitis. This is the diagnosis. This was the diagnosis. Discitis. This is actually the diagnosis. And remember, in case of discitis, in the PACES exam, you will be given a specific clue of the route of the entry of the bug into the body. In this case, this was skin scratch. Sometimes there can be history of IV cannulation. Sometimes some IV drug user, something like that can be there. But in that exam cases, that was skin scratch. Wonderful, Dr. Nikita. Sorry, Dr. Nikta. Then another case. A 35-year-old lady She is a lady with low back pain. This pain is for 1 month. The vitals have been given outside. The blood pressure is 150/85. After entering into the station, you are seeing that she has localized weight gain mostly in the central part of the body. And she is recently diagnosed with high blood pressure and high blood sugar. She is a patient of bronchial asthma and taking prednisolone tablet. Prednisolone 10 milligram for the past 2 months. So what is that? Dr. Shubhas has already answered. Can anyone tell me the reply? Tell me the answer.
Osteoporosis due to iatrogenic Cushing.
Yes, osteoporosis due to iatrogenic. This case has come many times. Many times. Osteoporosis due to iatrogenic Cushing. In many centers, this case has come. Recently, in the diet one, in the Dhaka, this case has also come. Osteoporosis due to iatrogenic Cushing. Is this clear? Then tell me another 30-year-old female with low back pain. So this low back pain is there for 1 month. And after asking the history, she is telling that she is having loose motion. This loose motion is there for the past 6 months, which is watery and related to the bread pasta. So what is the cause of low back pain in this patient?
Intermittent arthritis.
Celiac disease.
Wonderful.
Yeah.
Celiac disease. It will be celiac disease. Because I have told that this loose motion is related to bread and pasta. Remember, this is celiac disease. This is real exam case that has come in the PCS exam. Young patient with loose motion. This loose motion is there for 6 months. It is already there. It is not actually reactive arthritis. It is celiac disease. Then let me ask you another question. A 50-year-old female with severe low back pain. Let me just mute one and something there is. Okay. With severe low back pain, and she has a past medical history of breast cancer, and it was cured 5 years back. So what is the cause of low back pain in this patient?
Bone meds.
Wonderful, bone meds. So isn't that much easy? Whenever you go to the past medical history earlier, you will get the diagnosis in a very easy way. Actually, long clinical consultation is not that much tough that we think. It is very much easy if you go in a proper way. So then another case, 35-year-old male with low back pain. He has a history of loose motion. Three weeks back. And he has history of casual sexual contact, that is unsafe sexual exposure.
Reactive
So what do
arthritis.
Wonderful. This is reactive arthritis. Actually, you have to exclude all the seronegative spondyloarthritis, but in this case, it is reactive arthritis, as there is history of loose motion there. So let me tell you another case. A 57-year-old man with severe low back pain. Sorry. The blood, and after entering the station, regarding the past medical history, he is telling that he had surgery of valve, and that was a case of mitral valve replacement. And also, he had a recent episode of flu. For that, he had taken azithromycin. That is evident in the drug history. So what is the cause of low back pain in this patient?
First hematoma.
Wonderful. Yes, was hematoma. So what do you think? Long clinical consultation is that much difficult? These are the real exam cases. I will provide the details of the PDF to all of you to make practice, and I will assess how have you practiced before the next class. You have to practice each individual with me. So these are the real exam cases that has come. And remember one extra thing, that is cause of low back pain in Marfan syndrome. That is separate from this. This is actually syndromic diagnosis. The cause of low back pain in case of Marfan syndrome is dural ectasia. Also, kyphoscoliosis or kyphosis can be there, but this is different. Dural ectasia. This case has also come in the basis exam. Low back pain. After entering the station, you are seeing that the patient is Marfan syndrome. So that differential diagnosis of low back pain in this patient is either dural ectasia or kyphosis or kyphoscoliosis. So these are all about low back pain. Do anyone have any question regarding the approach to low back pain? Any kind of question, please feel free to share with me. Okay, wonderful.
Sir, is the low back pain in celiac disease is due to osteoporosis?
Yes, most likely due to osteomalacia that has led to the osteoporosis.
Okay, thank you.
Because it's due to the malabsorption of fat soluble vitamin like A, D, E, K. She is not able to get enough nutrition. Vitamin D deficiency has led her to the osteomalacia and eventually osteoporosis.
Okay, okay, sir.
Okay. So next, now go to the next case. This is also a very important case. That is knee pain. Actually, this case comes every now and then. The knee pain. This is also a triple ester case. So how to approach to a case of knee pain? It is also the same. After entering the station, you have to ask whether he or she has any morning stiffness, and if the morning stiffness is more than 30 minutes or less than 30 minutes. If it is more than 30 minutes, then the differential diagnosis is either spondyloarthritis or rheumatoid arthritis. So there are 4 spondyloarthritis I have already discussed in the case of low back pain. Then if it is there is no morning stiffness, then this is mechanical. And the mnemonic for mechanical causes of low back pain is GHOST. This is my mnemonic. So what goes for GHOST? G goes for gout, pseudogout. H goes for hemarthrosis, O osteoarthritis, S goes for septic arthritis, and T goes for trauma. I will discuss one by one how to exclude each one of them. So apart from this, after asking the morning stiffness, you have to analyze the symptom using the OD-para. And you have to grade the pain using the LICO. And actually, there is no red flag sign in case of low back pain. Red flag sign will be there in case of knee pain. Red flag sign will be there in case of low back pain, but in case of knee pain, there is actually no red flag sign. So this is different from the low back pain. So how to screen for each disease? I have already discussed how to screen for psoriatic arthritis, enteropathic arthritis, and reactive arthritis. And for rheumatoid arthritis, you just have to ask, is there any other joint pain? Whenever the patient tells you that I have also pain at my left knee, apart from the right knee, and both the pain are same, and there is morning stiffness, then this is rheumatoid arthritis. Apart from that, whenever approaching to a case of knee pain or low back pain, you have to ask any other joint involvement, because you will get a clue from this question. Suppose whenever a patient tells you that I have knee pain, apart from that I have pain occasional pain at the base of my great toe. So what can be the diagnosis in this case? Can anyone tell me? I'm telling it once again. This is a mechanical. Sorry.
Great toe gout.
Yes, gout. Whenever anyone tells you that I have knee pain, apart from that, I have occasional episode of pain at my grade 2. This is gout. I'm discussing it one by one. Wonderful, Dr. Neha. So what are the causes of mechanical causes of low back knee pain? Gout, pseudo-gout. So what are the causes of gout? To remember the causes of gout, there is a simple mnemonic, that is DHL and psoriasis. DHL is the name of parcel company, we all know that. So what goes for D, H, and L? Actually, there are 3 Ds. One is diet, one is drug, and another D is defect in kidney function. So you have to ask, what about your diet? Do you take excess meat product or sea fish? You have to ask the drug history. You have to assess whether he is taking any thiazide diuretics. You have to ask about the kidney function. Any decrease in the amount of your water work. In the renal section, you have to ask what about your water work, what about the amount, color, frequency, frothiness. At that case, you will get an evidence of the CKD there. So CKD is a cause of gout. Then H. H goes for 5H. What are the 5H? The 5H of history of high blood pressure, history of high blood sugar, history of high cholesterol, then history of excess alcohol, and history of smoking. These 5H can lead to gout. Then comes the L. L goes for lymphoproliferative and myeloproliferative disorder. To screen for lymphoproliferative and myeloproliferative disorder, you just have to ask triple L. That is loss of weight, loss of appetite, lumps and bumps in the body. You can ask this question for screening any kind of cancer. That is triple L. Loss of weight, loss of appetite, lumps and bumps in the body. And if there is psoriasis, there will be skin rash. You will get it. So these are the causes of gout. And in case of gout, you have to ask, apart from this knee pain, do you have any other joint pain? If the patient tells you that I have pain at my great toe, then this is gout. Then pseudo-gout comes in the PACES exam on the background of hemochromatosis mostly. Also, you can remember Wilson disease. But in the PACES exam, I have seen hemochromatosis comes as a case of pseudo-gout. This hemochromatosis mostly occurs as a case of secondary hemochromatosis, like the patient is a case of thalassemia patient, and he is taking repeated episode of blood transfusion, and the case is given to you as a case of knee pain. So the cause of knee pain in this patient is pseudo-gout. Then H for hemarthrosis. In case of hemarthrosis, there is typically, in the past medical history, there will be history of bleeding disorder. Most likely, in this case, hemophilia. Then O for osteoarthritis. This is the most common case, comes in the PACES exam because this is very much easy to give. In the osteoarthritis, you will be seeing that it is an old age lady with some heavy weight. You have to elicit the crepitation during the passive movement. I will discuss one case by one what physical examination you have to do for the knee pain. You have to do the physical examination in the form of look, feel, move. In the look section, you have to see whether there is any swelling or redness. In the feel section, you have to first check the temperature, then you have to check the tenderness, then you have to check for tapping. Tapping means you have to tap upon the knee joint to see whether there is any swelling there. Then function, look, feel, move. In the move, you have to first do the active movement, and during the passive movement, you have to check for knee crepitation there. If there is any knee crepitation or not. So this is osteoarthritis. S goes for septic arthritis. This is also very common. Usually in the PACES exam, septic arthritis comes with a history of instrumentation in the knee joint. Like she had a history of osteoarthritis and a history of intra-articular steroid injection. Now she is having knee swelling, knee pain, and fever. Sometimes there can be also history of uncontrolled diabetes with history of injury to the skin. Like that case I have already discussed, discitis in case of low back pain. And you have to take history of trauma also. So this is the approach to the knee pain. If this is clear, then I can discuss some real exam cases. Please tell me whether you are clear about the approach to the knee pain. Okay. Now let me discuss some real exam cases. And also, in case of knee pain, examine the gait during the physical examination. By examining the gait, you are excluding the complication, whether she or he is able to walk or not. So let me tell you, a 65-year-old female with knee pain. She had already knee pain there, but for the 3 days, the pain is increased. She has also raised temperature. She had a history of wearing, she is telling you that she had a history of wearing and tearing of knee joint. So what is the cause of knee pain in this patient? Can anyone reply? Sorry?
Septic arthritis.
Septic arthritis. This is real exam cases. This came in the basis exam. So there was a history of instrumentation. I just did not tell you to see whether you are attentive or not. There was a history of intraarticular steroid injection. Okay. Now come to the next case. A 40-year-old male with bilateral knee pain. This case actually came in the Cairo, and he had history of he had in the past medical history, he had history of infertility. And the pain is mechanical in nature with history of infertility. So can anyone tell me what is the cause of knee pain in this patient?
And he stand.
Yes, he is stand. Wonderful, Dr. Neha.
This.
He is stand.
Mm.
What is the cause?
So hemochromatosis.
Yes, hemochromatosis. This case came in the Cairo Center. Wonderful, Dr. Neha. Then another case, a 50-year-old male with the same knee pain. And he is also telling that he feels fatigue. That is weakness. Regarding the past medical history, he is telling that he is having some bleeding disorder. That's why he has history of repeated blood transfusion.
Leukemia.
What is the cause of knee pain in this patient? And he has stigmata of CLD also.
Hemarthrosis.
I remember he has repeated episode of blood transfusion. He has stigmata of CLD. He has fatigue.
Hemarthrosis. But CLD does not fit in it.
Yes, that's why I'm telling. What is that? Wonderful. Dr. Shubhas has answered. Hemochromatosis. This is secondary hemochromatosis. Are you getting this? Is it clear to everyone?
So why blood transfusion?
She is a case of thalassemia. He is a case of thalassemia. Not thalassemia, some hereditary spherocytosis, something like that. Some bleeding disorder were there, and due to that bleeding disorder, he was having repeated blood transfusion. And that happened, that caused secondary hemochromatosis. Are you getting my point, Dr. Neha?
Yes, sir.
Any confusion regarding this case?
Sir, is it due to pseudogout in secondary hemochromatosis?
Yes, it is pseudogout. It is due to pseudogout.
Okay.
Because in the basis exam, whenever you ask the past medical history, maximum time the patient cannot reply the pinpoint diagnosis. He or she will reply that I have some bleeding disorder, but I don't know the name. This is intentionally hidden. So whenever anyone has bleeding problem and he has repeated episodes of blood transfusion, and after entering the station, you are seeing the stigmat of CLD, like the hepatic phase, enlarged tummy, and he has a tanning of skin, and also the knee pain. This is due to secondary hemochromatosis. Is it clear to everyone? Another case, 65-year-old female with knee pain. After entering the station, you are seeing that she has some hand deformity, like swan neck deformity. So what is the cause of knee pain in this patient? Very much easy.
Rheumatoid arthritis.
Yes, rheumatoid arthritis. This is very much easy. Then come to another case, a 55-year-old female with the prompt was joint pain. After entering the station, the female told that she has right knee pain and low back pain. And in the past medical history, she is telling that she had fever and diarrhea 2 weeks ago. Sorry. Fever and diarrhea 2 weeks back. And it lasted for 2 days and it was watery. Then the right knee pain started. Afterwards, the back pain. Back pain was so severe that she is taking ibuprofen. So what is the cause of low back pain in this patient? And this pain is inflammatory. That is, she is having morning jamming. Yes, wonderful. Dr. Subhas has answered. Can anyone answer?
Reactive.
Yes, reactive arthritis. This is that much easy. This is reactive arthritis. Then another case, a 45-year-old male with knee pain. So after entering the station, you are seeing that a lean and thin male with question mark posture. He also tells you that apart from this knee pain, I have low back pain. And this pain is, and he is also having morning jamming. So what is the cause of knee pain and low back pain in this patient? Can anyone answer?
Ankylosing spondylitis.
Yes, ankylosing spondylitis, but better to tell it seronegative spondyloarthritis. It was a case of actually ankylosing spondylitis. Is it clear to everyone? These cases come in the PACES exam. Is this clear to everyone regarding the approach to the knee pain? If it is clear, then I can proceed with the next case. Should I proceed? Okay. Then another triple star case is ankle pain. This prompt has already come in this Diet 2 exam. And most of the cases in the exam, it comes either on the background of spondyloarthritis or Charcot joint. Charcot joint is the single most important differential diagnosis for ankle exam for PACES exam. The approach is almost the same, whether there is any morning stiffness or not. If there is morning stiffness, this is either spondyloarthritis or reactive arthritis. If no morning stiffness, then the mnemonic ghost is the same plus Charcot joint. But in the PACES exam, what comes in the PACES exam is the Charcot joint most. Charcot joints comes in the PACES exam every now and then. And remember, if the joint is Charcot joint, you cannot examine the movement of the joint. You cannot manipulate the joint. If you manipulate the joint, you lose mark. This is the important thing to remember during examination of the Charcot joint. For the Charcot joint, you just have to look and just have to feel, but don't go for the movement. And this Charcot joint will come as a complication of the diabetes, long-term uncontrolled diabetes. So you have to ask all the questions of diabetes. You have to screen for the microvascular complication, macrovascular complication, and also the autonomic complication. You have to examine for the peripheral neuropathy. You have to offer fundoscopy and urine depistic. And remember, in recent days, fundoscopic examination is being given every now and then. So you have to know how to do the fundoscopic examination and pick up the findings. And you don't have to know much details. Just know, just be able to know what is papilledema, what is hard exudate, what is soft exudate, and what is bleeding spot. You don't have to know the staging of diabetic eye disease. Whether you are being able to identify the hard exudate, soft exudate, or bleeding spot, that is more than enough, and you will pass. But practice this fundoscopy. And remember, during doing the fundoscopy, don't put hand over the patient head. If you put your hand over the patient head, this can kill your mark in the PCS exam. So Charcot joint is the single most common and important case that comes in the PCS exam. Apart from this, ankylosing spondylitis in the form of seronegative spondylitis has come in the PCS exam for the ankle pain. And this is a very much important case for PCS exam. So these are the 4 prompts that are most important under the category of musculoskeletal system. That is hand pain, back pain, knee pain, and ankle pain. And I suggest you to go through this prompt and know ins and outs, because the triple star prompts comes every now and then. You have to know the details of the prompts. And this is very much easy. There is nothing so much extra in these cases. You can cover all the things of these cases, but you have to go through the cases. You have to go through the prompt. And these are very much important: the hand pain, low back pain, knee pain, and ankle pain. Because these 4 prompts comes every now and then in the PCS exam. Then I'm going to discuss about the less important. First, the double star cases, then the 1 star. So there are 2 double star cases. One is hip pain and another is shoulder pain. So in the PCS exam, hip pain, whenever a patient comes with hip pain, you have to analyze the symptom using the ODPARA and LICOR. And there is also no red flag sign. And in the PCS exam, hip pain always comes as a case of avascular necrosis of the hip joint. There will be a history of either steroid or alcohol or sickle cell disease. And the sickle cell disease usually comes in the Middle East. It does not come in the India and Bangladesh. It usually comes in the Middle East. Sometimes hip pain can occur as a case of osteomyelitis due to the salmonella diarrhea. He or she has a history of diarrhea or loose motion. Now he has hip pain. This can be due to salmonella osteomyelitis, but these cases come more than 3.5 years back. This has not come in recently. But the avascular necrosis sometimes come. Suppose there is a case, I'm telling you, a case has come that 25-year-old female with hip pain. So in the past medical history, she is telling that she is a patient of renal transplant. And in the drug history, she is taking tacrolimus, mycophenolate mofetil, and also prednisolone. So what is the cause of low back pain in this patient? Can anyone reply? Very much easy.
The vascular necrosis due to prednisolone.
Yes, avascular necrosis due to prednisolone. Another case came like a 40-year-old female with hip pain. And in the past medical history, she is telling that she is a patient of bronchial asthma. And in the drug history, she is telling that she is taking prednisolone. This is also the same. That's why I'm telling you again and again, going to the PDF, that this past medical history, drug history, and family history earlier is one of the very much important trick to reach the definitive diagnosis earlier. After analyzing the symptom, directly go to the PDF. You will get your diagnosis. And regarding the past medical history, drug history, and family history, what questions you have to ask? You have to memorize it earlier, because in the exam there is not much time to think and answer. Because in the exam center, what I think that the central memory does not work. What works is the peripheral memory, like the muscle memory. You just have to practice earlier. In the exam, just have to perform. In the exam, there is not much time that you think and perform. Because if you put something for the exam that I will think and perform, you will miss something. So this is hip pain. Then another case is, sorry, a slide is missing. We can discuss. This is shoulder pain. In the PACES exam, shoulder pain comes as a diagnosis of, sorry, excuse me, let me. Just give me 1 minute. Okay. In the PACES system, shoulder pain actually comes as a case of frozen shoulder. Typically with the history of diabetes, you have to analyze the symptom using the OD-para, then liquor, then you can directly go to the past medical history, and whenever in the past medical history you can get a clue that the patient has diabetes, then the diagnosis is shoulder. But what would be the differential diagnosis? The differential diagnosis of frozen shoulder will be like supraspinous tendinitis. You have to tell the differential diagnosis also to get the full mark in the DD. Then osteoarthritis. Remember, in the supraspinous tendinitis, there will be pain at the tip of the shoulder. You have to examine the shoulder. First, the active movement, abduction, adduction, then forward flexion, backward flexion. First active, then passive. In case of frozen shoulder, both type of movement will be painful. In supraspinous tendinitis, anterior portion of the tip of the shoulder will be painful. And passive movement will be possible, whereas in the frozen shoulder, both range of movement, like the active and passive movement, will be painful. But in case of frozen shoulder, supraspinous tendinitis, passive movement will not be painful. Whenever telling the differential diagnosis, you have to tell the examiner in this way. Another differential diagnosis is osteoarthritis. So these are the 3 important differential diagnoses for shoulder pain. And I have forgot to tell one important thing, that whenever there is any pain, the patient tells you that I'm suffering a lot for this pain. First, you have to empathize, give empathy to the patient, that I'm really sorry for your suffering. Let us say, how can we help in this regard? And if there is pain, you have to offer painkiller instantly. Just tell the patient that as you are having severe pain or pain that is hampering your life, or you are suffering for this pain, I'm going to give you some pain medication at the end of our conversation. How does that sound? You have to tell this to the patient, because it will carry mark. So remember this thing, whenever there is any pain, offer painkiller. So this is all about shoulder pain. It comes frozen, as a case of frozen shoulder. You will get a clue from the past medical history of diabetes, but the differential diagnosis is supraspinous tendinitis. In supraspinous tendinitis, the anterior part of the tip of the shoulder will be painful, and passive movement will be possible. Passive movement will not be painful, but in frozen shoulder, active movement and passive movement both will be painful. And in osteoarthritis, you will find crepitation. So you just have to tell the differential diagnosis. So this is all for shoulder pain. Then come to the 1-star cases. The first 1-star case is neck pain. Actually, the PACES exam, I have seen this case coming only for one time. The 1-star cases are those which I have found coming for only one time. The neck pain, that case was a case of ankylosing spondylitis. So after anti-testation, if you are seeing that he has morning stiffness, then this is either ankylosing seronegative spondyloarthritis or rheumatoid arthritis. And if there is no morning stiffness, it can be cervical spondylosis, cervical radiculopathy, or cervical myeloradiculopathy. But the case I have found, that was a case of ankylosing spondylitis, that is neck pain with morning stiffness. And remember, ankylosing spondylitis is a very much common case in the PACES exam. You have to know everything, what to do examination for any case of seronegative spondyloarthritis and ankylosing spondylitis, like the extra-articular complication and also the articular complication. The patient can come in with a complaint of, let me discuss with it about in a little. Like the ankylosing spondylitis patient can come to you with low back pain. I was given this case in my exam. So the extra-articular complication you can remember in the mnemonic of 5A. From the eye, that is anterior uveitis. At the lung, this is apical fibrosis. At the heart, this is aortic regurgitation. At the tummy, this is amyloidosis. You have to look for hepatosplenomegaly, and also the frothy urine for amyloidosis. And at that leg, it is Achilles tendonitis. The articular complication is low back pain and neck pain. You have to check 6 movement of the neck, forward, backward, side to side. There are 6 movements. And at the hip joint, or low back pain, first you have to check for the 4 movement. First side to side, then backward and forward. And you have to offer the Schobert test. That is, you have to offer the modified Schobert test, not the Schobert test. Or you can offer either Schobert test or modified Schobert test. But you have to know how to do that test, and you have to do that test in the exam. I had to do the exam I had to do the Schobert test in the exam. So you have to know how to do the modified Schobert test. The Schobert test is done in the way that first identify the dimple, then draw a line, joining the 2 dimple, then identify 10 centimeter above point. Then tell the patient to bend forward and see whether it increases more than 5 centimeter or not. You have to measure it and you have to show it to the examiner. After doing the Schobert test, you have to do the heel to wall test and occiput to wall test. You have to tell the patient that, can you please stand against the wall with your feet close apart. Then you have to measure the distance between the occiput and wall and between the heel and wall with a measuring tape. This is very much important. So ankylosing spondylitis has come as a case of, neck pain has come as a case of ankylosing spondylitis. Then diffuse body pain is another important. That is one extra important case. So what are the important differential diagnosis for diffuse body pain for PACES exam? Remember, I'm discussing the important differential diagnosis for PACES exam. There are lots of cases for diffuse body pain. You will get lots of cases in day-to-day practice, but I'm discussing the cases that are assessed in the PACES exam. It is not for the regular day-to-day practice. Remember this thing. So the important cases that came in the PACES exam is dermatomyositis or polymyositis with diffuse body pain, then rhabdomyolysis with history of drug like a statin or illicit drug or exercise-induced, like the patient take part in marathon, and viral myalgia, like the patient has any flu-like symptom or recent flu-like symptom, osteomalacia with a history of had a history of loose motion, Crohn's disease, had a history of colostomy, and also it came with a prompt of polymyalgia rheumatica. And in all case of diffuse body pain, exclude the rhabdomyolysis. How to exclude the rhabdomyolysis? By analyzing the urinary symptom. You have to ask, what about the amount, color, frequency, frothiness? Because in case of rhabdomyolysis, the amount is reduced, the colors become high, and that's all the evidence of rhabdomyolysis. You have to offer the sitting and standing blood pressure.
Thank you.
Looking for any postural drop, or if there is any postural drop or not. So this is all for diffuse body pain. So let me give you some example how the case came in the PACES exam. It is becoming a little bit boring. That's why this is a real exam case. Sorry, now it's coming. So I have to mute someone. So let me discuss a case, some cases that real exam cases. A 40-year-old male has come with diffuse body pain. After entering the station, you are seeing that he has some colostomy bag with him. Regarding past medical history, he is telling that he is a patient of Crohn's disease and he had surgery for this. That's why that colostomy bag is there. So what is the cause of diffuse body pain in this patient? Can anyone tell me? Can anybody answer what is the cause of diffuse body pain in a patient with colostomy bag due to Crohn's disease? Am I audible?
Is it hypokalemia?
Not likely.
Sir, show
again.
please once more of
Yes. From PTP has answered. I don't know what is PTP. It is actually osteomalacia. Because he had resected some part of his bowel. He had resection of some part of his bowel. That is causing malabsorption. And he is getting less vitamin D. Are you getting my point? These cases come in the PACES exam. And due to low vitamin D, he has developed osteomalacia with diffuse body pain. Is this clear?
Yes.
And remember, in this case, there is an important thing that the candidate make mistake in the exam. The mistake is you have to examine the colostomy bag. But what you have to examine? You have to open the mouth of the bag and see the content. But don't remove all the mouth part of the colostomy bag. Don't remove the whole part of the colostomy bag and make it open. Just open the mouth. There is a chain there. There is a opening that by which the patient disposes his fecal matter. Just open the mouth only. Don't remove the whole part. If you remove the whole part, at that center, the candidate lost mark. You just have to open the mouth and see the contents there, the contents of the colostomy bag. Am I being able to make it clear, or should I repeat? Please inform me whether it is clear or not, because this is important. Whenever a colostomy bag happens in the PACES exam, you have to check the content by opening only the mouth, but don't remove the whole portion of the colostomy bag. Is it clear to everyone?
Yes, sir.
Okay. Please keep this in mind because it can be given in the PACES exam. Then another case this also came in the PACES exam. 50-year-old male with diffuse body pain for 2 days. Taking the drug history, there's a history of statin intake. He had recent flu-like symptom, and he does exercise. So what is the cause of diffuse body pain in this patient?
post-viral myalgia.
Wonderful. Anything else?
Statin-induced.
Yes,
myopathy.
statin-induced. Yes, statin-induced myopathy. And he is doing exercise and he has started taking NSAID because he is feeling pain. And recently, his water work has reduced. So what important safety netting we have to tell the patient?
Stop statin and NSAIDs. Get
Wonderful.
Done.
Yes. Stop statin and NSAID. If you don't utter this word, you will lose your mark. Remember, this is very much vital. Whenever there is a culprit drug, just tell the patient, stop that. The examiner will put his ear to you, whether you are telling to stop that medication or not. This is very much crucial. These are the important parts in the exam that carries a huge mark. So these are the cases under the diffuse body pain. And the last case was there, the pain in the great toe. It is very much easy whenever there is a pain in the great toe, this is due to gout. And in the gout, I have already discussed the DHL plus psoriasis. I hope this is clear to everyone. This has come in the basis exam only one time, only with the prompt of pain in the gout. But it came with the pain in the knee joint after entering the station. Whenever he was asked that any other joint pain, he told that, yes, I had some episode of pain at the base of my great toe, at the right great toe. But simply with the pain at the great toe, it came only once time. That is gout. So these are all about the musculoskeletal system. And if you look for the cases, you will not find a single case outside of this prompt. And there are some prompts which covers both the system, like both the musculoskeletal and the endocrine. And this will gradually be discussed during the further session. So up to this point, if anyone has any kind of question, please feel free to ask me. Does anyone have any kind of question regarding the any prompt scenario, or how the case will be distributed, how it will be assessed, anything about the course structure? I'll be very happy to share the information. And I will provide the details recording of the, after today, I will provide the PDF sheet to individual one. And I will divide the cases between the members. And you have to practice it before the next class between yourself. And in the next class, I will assess how have you practiced by practicing a case with each one. And after that, I will provide all the PDF sheets of today's session, the musculoskeletal system, to individual one. Then I will give the homework of the next class. Do anyone have any kind of question up to now?
So what is LIQR in history?
Sorry, I did not
What
get
is
it.
LIQR in history assessment?
Oh, yeah.
LIQR.
LIQ word. Okay. LIQR means location. First, you have to locate where do you feel the pain. In any case of pain, we have to define the location. It is very much important because in case of low back pain, I have already discussed, you have to show the location of the pain. You have to tell the patient that, can you please show me the site? Because low back pain can sometimes come as a case of pyelonephritis. It has come in the basis exam, in the Pondicherry. Then you have to define the intensity. You have to tell that how severe is it from 1 to 10, 1 being the lowest and 10 being the highest. Then the patient will grade you how severe he is feeling pain. And after seeing the grading, you have to offer painkiller instant. Don't wait for the ending of the examination, because you can forget to give the examiner. If you offer painkiller to the patient, then it is safe set. You are it will give an impression to the examiner that you are safe doctor. You are meeting the concern of the patient. Then Q goes for quality. Quality is what sort of pain is it? Can you describe it for me? Is it dull, sharp, something like that? Then the patient will tell you that it is dull pain or sharp pain. In case of headache, she can tell you that it is a throbbing type of pain. Then R goes for radiation. So after starting from here, does it go anywhere else? Sometimes the low back pain can radiate to lower limb. Sometimes the headache can radiate to along the neck. That is neck stiffness. So you have to ask, does the pain go anywhere? So in short, this is LICO. Is it clear, Dr. Nitya?
Yes, sir. Thank you, sir.
Okay. So any other question from any participants? Okay. So if no question is there, then I'd like to end the session, and I will send the recording to the active participants within tomorrow morning after I get the recording. And I will, within today night or tomorrow morning, I will distribute the cases among you, and you have to practice the cases with your partners, with the other participants of this group. And if any type of problem you face, please come back to me at any time. You can ask me through the inbox at the WhatsApp. I will try to meet your concern. But in the next class, you have to practice the cases with me. And after that, we'll discuss the prompts of the next class, that is the gastrointestinal system. In this way, the course will run. So that's all for today. I hope everyone has been benefited from today's session. If any concern comes in the way, please contact with me. Thank you all for attending today's session. Thank you very much. Good night.
Thank you, sir. Good night.
Thank you, sir.
Thank you.